So can you start by briefly introducing yourself and explaining your journey with OT, kind of how you got to where you are?
Okay, so I started as an OT a long time ago. I graduated with Dr. Cleghorn, believe it or not.
Oh, no.
So that dates me. Well, actually, she was like a returning student in the class, so don't judge me age-wise by her. But I started out in adults, just like a lot of people do. I took the first job that was available and um, kind of evolved from there. So I started in subacute rehab, and then I moved to another subacute and eventually made my way into acute care at the hospital. I did primarily adults for a while, for about 5-6 years. And then I was the only one, because I had my own children, I was the only one that dared to go into the children's hospital and help cover. And obviously with pediatrics, it's really an all or nothing. You either love it or you don't want to touch it with a 10-foot pole. And I got sucked in and fell in love. And when a position came open, I took the pediatric position in the inpatient hospital, and did that for, like probably close to 10 years. And then about 6 years ago, the person who had kind of started the home health program for pediatrics within Spectrum Health had really become a friend of mine and really wanted me to come over. And I was then going to have the opportunity to do infant feeding. And so I took it. I jumped and took the leap and started in home health, all pediatrics. And really kind of just started to realize that, as much as I can help a lot with infant feeding, there was that pull, like always those parents that have that desire to get to breastfeeding. They've come out of the NICU under tons and tons, they maybe had a really long NICU stay or whatever. And the one thing that mom has always wanted to do is be able to breastfeed. And so I decided that I wanted to have some more knowledge under my belt in that area. So I took the certification for lactation counselor and love it. And that's what and so it's not my primary thing that I do, I wouldn't say, but it's definitely one of the tricks in my tool bag now, that I feel much more confident when I have a mom. And I also have the flip side of that, of the baby's special needs, to be able to give that mom guidance as to whether it's really just not going to be a possibility for their full nutrition, but maybe they can just do some comfort nursing and we can work towards whatever we can set that goal to be realistically, or whether I can provide that encouragement to that mom to be like, I don't see any reason that this baby can't begin to transition over to breastfeeding at some point, and that we can work together on that. We can assess issues fairly quickly. She doesn't have to then, join a whole separate lactation groups, which don't even exist anymore right now. And I think that was one of the best things through this whole COVID thing, is a lot of things were shut down when I was not. And so I was still able to continue to work with some of those moms. And so that's kind of how I've gotten to where I am today, I guess. So yeah, does that answer that question?
Yeah, it does. That was really helpful. Thank you.
Okay. So yeah, so I do have my CLC. I do not have my IBCLC.
What is that?
Okay, so your CLC is your Certified Lactation Counselor, mm-hmm. and your IBCLC is your International Board Certified Lactation Consultant.
Oh, okay.
So your CLC certification is, it's two different pathways to be able to work directly with breastfeeding dyads. One is generally like the CLC, I did a week-long course and then a certification at the end of that course. The IBCLC, you have to have X number of hours in lactation experience before you can sit for the exam. So a lot of people will get their CLC, get their experience, and then get their IBCLC. But both of us can be lactation counselors in a hospital or wherever. I generally, though, if you're going to bill, I think under lactation directly, I think you need to have your IBCLC. I bill under OT.
Okay. That's a helpful discussion. Thank you.
Mm-hmm. So I don't know the ins and the outs as far as if you were a nurse, with a CLC versus an IBCLC, and how they work that in the hospital, because there are codes specific to lactation counselors, but I think those are for the IBCLCs. Okay. Okay.
Great, thank you. And we know that you just got back from vacation. You had your first day at work, it looks like. So what does a typical day at work look like for you?
Okay, so I work in home health. So I see all of my babies in the home. So I generally see 4 to 5 or 6 babies in a day. And I try to obviously catch their feeding times. Generally, they're coming out of the NICU, so they're coming off of that NICU schedule. And so I can try to catch them on some sort of a schedule. But then my job is to go in and assess that feeding and what's going on, what can we do to make it more efficient, safer, get them off a feeding tube or wherever, kind of whatever direction things are headed in. But that's my general day, is that I actually start from home. I don't go to the office. I go straight to my first visit, and I kind of do about 45 minutes to an hour at each home with a half an hour drive time between. And then I have a little bit of paperwork when I get home at the end of the day. That I can do right when I get home, or I can save that till later, or whatever. It's supposed to be done by the end of my day.
Awesome.
So that's kind of my typical day.
Yeah.
What are the other professionals that you work with or that are on your team?
Yep. So what I would call my direct team, I work closely with a nurse. I work closely with my PT. And then I don't work as closely with speech therapy, simply because in home health, we're both doing feeding therapy. And so I don't generally share patients with her unless it's a case that one of us is seeing for feeding, and then they need to have that kind of more traditional side of the discipline added. So if I have a child that I'm seeing for feeding, but they're old enough that they should be seen for language development, the speech therapist will come in. If she is seeing a child or infant for feeding and we're getting to the age of working more on reaching and fine motor and separating that out more from what PT's been working on developmentally with them in those very early months, then I will come in. So those are I would say my direct team, but certainly I do a lot of communication through the computer with physicians like neurodevelopmental pediatrics, pediatricians, and specialists like pulmonology, GI, that kind of thing. So, but not on a as direct basis usually.
So you told us about your timeline and kind of how you got to where you were. What are some barriers or challenges that you've encountered during that process, or during specifically the practice in this feeding and lactation setting?
Oh, let's see. I haven't had too many barriers. I think one of the toughest barriers, since I do work with preemies, is their catch-up growth is so important. And so trying to find that balance between supporting that breastfeeding and sometimes having to support that catch-up growth and that need for fortification and added calories beyond what breastfeeding can give. So for some of my preemies, there is a limit to how much they can breastfeed, or they aren't going to grow and get onto the charts where they need to, when they need to. And sometimes, most of the time, parents are very understanding of that. But sometimes that can be a challenge. Let's see. Barriers or challenges. I don't get a ton of barriers in my setting. In fact, I get most of my colleagues actually asking me to come and consult on a case that wants to do some breastfeeding or that's having some issues with a latch or, that kind of thing. So they're much more wanting to pull me in if they haven't gone through the course themselves or that kind of thing. I do know there are a few challenges in the hospital, in that I know a speech therapist who also has her IBCLC, but has not been able to successfully get a job strictly as a lactation consultant in the hospital because they only hire nurses with their IBCLC. Okay. So I know she's had some pushback at the hospital level from that regard. But as far as what I do, and I've even had some patients that will also consult with another lactation counselor, either before I've seen them or while I'm seeing them, or that kind of thing. And I haven't had any major issues or barriers with that, I wouldn't say.
So when you work with moms, whether it was when you were in the hospital setting or at home, what are some of the most common questions you're getting from them?
Certainly, one of the most common questions I get is, strategies to increase their supply. Obviously, the $1 million question is, when can the baby's tube come out? When are they going to take everything, by mouth? Am I going to be able to breastfeed? Am I going to be able to breastfeed at all? Like, when am I going to be able to start doing that? Those kinds of questions are my primary questions that I get for sure.
And then what are the most common strategies or techniques that you use in your interventions? When doing some research, we found a lot about establishing routines. And I know that you also mentioned that you try to get to those feeding times when you are doing the home health visits. So I kind of made that connection. But so what are those most common strategies and techniques that you typically use?
Yeah, so it is interesting, a balance between establishing breastfeeding and establishing feeding routines, because obviously in order to establish successful breastfeeding, they really need to breastfeed on demand, which really can make it a struggle for either or both the baby and the mother. If they've been on a very strict NICU schedule, where in the NICU, those babies are only fed every 3 hours. They're on a very tight schedule to allow specific care times and minimize the overstimulation to a baby. But in the home setting, it's a whole different ballgame. And so some families really thrive on that NICU schedule, that routine they can bank on and plan on. But sometimes as we transition over to breastfeeding, that schedule has to be driven much more by the baby, and teaching parents more about reading those cues from the infant and trying to get them to understand that it's okay if they breastfeed every hour and a half, even though they didn't feed every hour and a half in the NICU. But then also, because it's nearly impossible in the home setting to know exactly the volume that baby took at that breastfeeding, everybody's always nervous about every last ml that goes into that baby, and it's under a microscope for a long time to make sure that baby is growing the way that they should. And that can be really challenging for your type A moms that really want to know that baby is doing what they're supposed to and getting in enough and growing. And so that's probably one of the things that we work on, it's tough to ride that line sometimes and create that balance for them. Mm-hmm. Other strategies, so specific to lactation, I would say one of my most common strategies is if they're allowed to comfort nurse, if they're not taking much by bottle, if they're not able to take by bottle, if they, as long as they are not a silent aspirator, I will strongly encourage that comfort nursing, even if the baby's it's not the baby's primary nutrition for that feeding or any feeding, for a few reasons. The obvious ones are for the bonding with mom and the infant, as well as the supply. If that baby's on breast milk and sensitive to formulas, I need to keep that mom's breast milk supply up, and baby is the best thing to do that. And so if on a very, very basic level, if I can at all encourage comfort nursing, I will absolutely do that. And then from there, it's really a matter of working with the mom of what is her goals and how can we work towards that. Or is it an unrealistic expectation that we need to find a kind of a compromise or somewhere in between that will work for both the baby and the mom. Certainly the most common strategies are just right in that the basics of a good latch, and trying to make sure that baby's getting a good latch so mom is not having pain or discomfort, because that's going to deter her from continuing on, whether it's comfort nursing or actual nursing. And so taking a look at that, making sure that is where it's supposed to be, watching that baby very closely during a feeding. Am I hearing that suck, swallow, breathe? Am I hearing any concerns from a swallow perspective or an endurance perspective that I need to be cautious about how much I let mom breastfeed? If we're on a really slow flow nipple rate, can that baby handle the breast flow rate, or do we need to change position? What do we need to do to try and help that baby be successful in both places? And then I think one of the biggest strategies that I use is probably my counseling, my therapeutic use of self. Like, one of the biggest things that moms need when they come home from the NICU is just that person to help validate that what they're doing, they're on track, that they're doing good, that there are things we can do to help, and that we can try to make it better, whether it be, maybe it's not going to be full breastfeeding, but there's lots of things we can do to still support at least part of that. And I almost never say never. As much as I can. There does sometimes come a time with babies where we have to have that discussion about if pumping is kind of driving you crazy, then we really need to look at a transition plan over to formula, because that baby isn't going to successfully breastfeed. And so those are some of the common things that I encounter. I probably am biased, but I do think I have one of the best jobs ever. And I've done a few different OT jobs.
That's
But I by far am biased that I think I have one of the best ones. I don't always love the office things or the behind the scenes things, but I love what I get to do with families for sure, and with babies.
That's great.
Would you mind telling, what is comfort nursing?
Okay, so sorry.
That's okay.
Comfort nursing is when the baby is allowed to breastfeed, but after mom has pumped. So it's not expected to be a major nutritional breastfeeding, but the breast is also never fully empty. So we will have mom pump, and then if the baby is interested and active at the breast, we will allow the baby to, I don't want to say act like they're breastfeeding, but basically like it's almost like a pacifier, but they will eventually get like a small letdown. But that's called comfort nursing. So it's not a full nutritional breastfeeding because mom has just pumped prior to, but it's still a comfortable experience, a comfort experience for mom and for baby. And like, it makes mom a little bit of the human pacifier, but in a really good way.
Probably a good bonding experience is
Yes.
what I'm getting
Yes.
out of it too. Mm-hmm.
It's as much or more of a bonding experience than skin to skin too. And a lot of times I will even start with skin to skin and just tell that mom to relax, kick back in a recliner and let that baby just lay on your chest, skin to skin, and let the baby do what it is naturally designed to do. And a lot of times that baby, I can have some of the most averse babies that will, I don't want to say independently, but go through the stages of like a newborn and find their way to the breast as they just kind of snuggle with mom and inch their way down. They're born to know what to do there. And I get moms that like are in tears when I come the next time because it was one of the best experiences. And they also, their supply is up, they're like, everything is good. And so, and something so simple. So, and like I said, unless they're silently aspirating, it is hands down a baby that's not able to take much of anything for nutrition. They might not have the best latch or anything like that. It's still a very, very beneficial encounter for both mom and baby. So, okay.
That's
so nice.
Sorry, I digress.
That's okay. You've talked a little bit about looking at the latch and like starting with that skin to skin. Can you tell us a little bit about what an initial assessment looks like for you?
Sure. So I don't have a specific assessment that I use. There is the Healthy Children's Project does have like a latch assessment that you can go through and that I went through as part of my certification. But because I do lactation as only part of what I do, then it's kind of a more overall assessment. So I start with some of the background of what has the baby been through. Are they on, like, medically, where is that baby from a stability standpoint? Where's their respiratory rate for their endurance and their respiratory support for that feeding? Are they on oxygen? Kind of, do they have a heart condition? Like, what's going on from that standpoint? Because that's a key and critical piece to infant feeding, is their respiratory support. So I often will start there. And where are they at? Can they sustain an awake, alert state with me? Can they suck on a pacifier? Do I do a brief oral motor assessment, checking for strength, for muscle tone, any tethered oral tissues like tongue ties and things like that? I try to minimize that as much as I can, because most babies don't really want you up in their mouth with your fingers. And I can't blame them. I don't like people up in my mouth with their fingers. I hate the dentist. So, so I'll do that. And then I'm looking at that baby's state regulation. Are they rooting? Do they act like they're hungry? Are they giving those cues that they know that it's time to eat? And are they ready for that feeding? And hopefully all of those things are a go, and we can introduce either a bottle or the breast. And so if we were going to introduce the breast, I'm looking at that position for that mom. What's going to be the best position for her as well as the baby? What do we need to do from a pillow support standpoint? Or where's going to be the best place to try breastfeeding for that baby? And I always start with asking mom, what have you already tried? Because if you try to jump in, she'll go with it, and then she'll say, yeah, I tried this and it didn't work. And you're like, oh, okay, well, that could have saved me like the last 10 minutes. So I always try to start with, where is that mom and what has she already tried that she's not interested in trying again? And where can we go from there? So then I'm looking at that baby. I'm looking, is mom inadvertently restricting their head movement for being able to get that mouth nice and wide open? Is mom's breast shape, size, things like that, is that affecting baby's latch, that we need to like help with getting enough of the areola and the nipple into the mouth for enough tissue? Kind of what's going on at that latch and at that time of latch. Is the baby's lips curled under? Is their cheek nice and rounded? Do they have a good seal? And then once they're on, it's a lot about hearing. What do I hear? And I really don't want to hear much of anything. I want to be able to see, but I don't really want to hear. I don't want to hear gulping. I don't want to hear clicking. I don't want to hear much of anything at all. And if I don't hear much of anything, and that baby's got their hand up on mom's chest and is kind of gently stroking it, they seem comfortable. I'm hearing very light swallows and suck bursts, and they'll take a little bit of a pause and keep going. That's what I like to see. That's perfect. And I'm going to step back, and I'm going to let well enough be. And I'm going to let nature take its course the way that it should. But if not, then we'll adjust those things. But really, there's a lot that can be done just within that latch and positioning to support that feeding 100%. So, okay, does that help?
Yeah, that was helpful. Thank you.
Okay.
Now, bringing it to the end of the process. So we just talked about assessment. Now I'm going to bring up discharge. You not only work with lactation, but also with feeding. So how does that process go with a mom and baby as you go from lactation to feeding and then to discharge?
Sure. So it depends on where that baby is. If everything's going really smooth for where they're at and what we expect, I will discharge them. And I will give mom, like, okay, if you see this in the future, this is when you need to talk to your pediatrician and get a referral either back to me or to another therapist. But within our Spectrum system, at least, I have the luxury of, there's an outpatient therapist at DeVos that also has her CLC. She's a speech therapist. And so if I have a baby that I know is working towards breastfeeding or working on breastfeeding and also still has some specialized needs, I will make that referral directly to her and make sure that they get to her caseload for a transition over.
Is that like, is there like an age limit where they would phase out of that program?
No. So we're not like early on through the schools.
Okay.
Early on through the schools is your like age divisions or whatever. We're through the health insurance. so there's a whole different set of kind of rules and laws and regulations. But basically, as long as there is a need, and they are making progress, from my standpoint for home health, there needs to be a medical justification for why I need to see that baby in the home, or they need to go to outpatient. And then the same thing rings true over there, that they need to have an established issue. They have to have, they need to be making progress and everything like that. And so it's much more steeped in your health insurance.
Would you say that there's a typical timeline or time period that you see these babies, or is it kind of just all over the place depending on
I would say it's a little bit all over the place, but 99% of my caseload is under the age of 2. And I would say 50% of them are under 6 months of age. So a lot of times I will start with them depending upon how complex their situation is. They will stay on my caseload for a lot longer than if I were to transition them over. So if I get that really early preemie, that 23-weeker that's home on oxygen, had some gut issues, that kind of thing, then I will stay with them as long as they're on oxygen if their insurance provides coverage. Usually around the age of 1, we're really trying to talk transition for sure if we haven't already transitioned them, unless there's like a really obvious reason. They're a trach and a ventilator. They've got like a lot of medical things going on that it's a no question they can't go to outpatient yet.
You kind of have alluded to this a little bit in a previous answer, but our next question is about, so we've seen breastfeeding referred to as a co-occupation between the mom and the infant. And we were wondering, what are some ways you address the mental health, bonding, attachment aspect of lactation and breastfeeding specifically?
Oh gosh. Yes, I would definitely say that it is, you can't treat a baby without treating a mother. Breastfeeding or anything. Like, you just have to be prepared that you have more than one client all the time, because there's always going to be a mom, a parent, or somebody that's there to support that infant, and to varying degrees having their own things that come into play there. But I 100% agree that breastfeeding creates basically feeding in general. I should say feeding in general, because I don't want to discredit my moms that bottle feed or choose to bottle feed or have no choice but to bottle feed. That can be just as much of a bonding experience. And the most frustrated moms, the most stressed moms are the moms that are not able to feed their infant at all. It is the occupation of infant feeding, whether it's breastfeeding or bottle feeding, is one of the most taken for granted occupations that I think there absolutely is. Because when a baby is born, that is the one and only thing that, like, one of the primary things a parent is expecting to be able to do for their child. And when they can't do that, they can feel very helpless. They can feel very discouraged and frustrated. It's not an area that every parent talks about, so they feel very isolated. They feel like they're the only ones that have a baby that won't eat or can't eat or whatever it may be, and they don't understand why. They just don't understand. And then it's often complicated by the well-intentioned grandparents that are like, oh, you just let that baby get hungry and they'll eat, they'll be fine. And that only makes it worse. And so it is very important to be very mindful of including that mom into the infant feeding experience. She is the primary person that's going to be feeding them, and addressing both of their needs. And I try very hard to kind of keep tabs on that of, do I have the mom that is like 110% on board and she's okay and she is going to pump until she can breastfeed that baby, whether it's at 6 weeks or 6 months? Or do I have that mom that's like at the end of her rope and it's a baby with a heart condition and we're really just spinning our wheels because that heart condition isn't moving forward like they thought it was, and that mom is at the end of her rope trying to pump and trying to feed a baby with a feeding tube and the baby's puking and the baby's in the hospital in and out and things like that. And I have to have that discussion of something has to give. And sometimes, and I don't tell them what they have to let go of, but I offer that if they need to let go of those breastfeeding hopes, that it is okay. And that we will work through it and we will get that baby eating someday if it's at all possible. And I've had very, very few babies that are not able to eat, literally not able to eat. They might just need to move on to a different program someday or whatever, depending upon the issues we end up with down the road. But yes, the dyad is 110% the most important thing with infant feeding in general, not just even lactation. But I think my moms that really had those high hopes of breastfeeding, if those hopes have to be like rerouted, those are the hardest.
For us and future students who are obviously going to hopefully become occupational therapists, do you have any recommendations for us or suggestions or just general advice if we're interested in lactation and how to maybe get into that field or advocate for it? Any advice on that?
Yeah, I think obviously the first place to work your way into is into pediatrics, and to work your way from there into feeding therapy. And sometimes you're going to work with toddlers and older children first and work your way down towards those infants, or in the NICU. Those kinds of places are great launching points for infant feeding. And then from there to branch towards lactation. I think one of the best things that I bring as an occupational therapist with a background in infant feeding to lactation is that I understand that not every baby is cookie cutter. And that's probably the one like ding that I have of your like La Leche League and a lot of your like lactation counselors that don't have the same background, is they're coming from a background of typical term newborns. And I think we bring a whole unique perspective when we bring in that special needs, that prematurity, the infant's unique and specialized needs into that feeding dyad, and be able to support that mom with a child that has specialized needs. And they're not going to get nearly as frustrated with us as the lactation counselor in the like general nursery that's like, well, here's a breast shield, here you go, you just need to kind of tough it out and it'll be fine. Because that's not a lot of times the situation. But I also don't have the same experience on the flip side, is I don't work with infants that typically don't have special needs either. But I think that's one of the unique things we can bring from our side, is that we're often coming from those children and infants with special needs into that
Our
dyad.
next question is about settings. So you talked a little bit about the settings that you have worked in. We're wondering if you could speak on settings that you could see lactation and infant feeding branching into, or if there's like benefits of one setting over another, just your thoughts on that.
Sure. So I'll start by telling you, we have a therapist in our NICU that is lactation. She's a lactation counselor. We have we have therapists in our children's hospital, like not on the NICU floor, but up on the general floors, that is also lactation certified. I work in the home with my lactation counselor certification, and then we have an outpatient therapist that's also lactation counselor certified. I don't know her personally, but I know of an OT in the area that has her own private practice. And that's what she does, is she is basically an in-home lactation counselor. And let's see, I'm trying to think of, so those are like the primary places. Certainly, I think if we can work our way into it, we absolutely have a place in that regular nursery as well, and bringing a different perspective. But it's a tough place to like break into because it's fairly strongly held by nursing staff. And part of that I can understand and respect, because what they do is they're birthing nurses. Oh my gosh, I'm sure that is not the term, but I could not. They're prenatal or perinatal nurses. they have them primarily get trained as well, which makes sense. The like nurse that has been with you through labor and delivery and then can be right there to immediately help you with lactation in the general nursery makes sense. And so that's probably one of the reasons it's been hard for them to wrap their head around hiring a therapist that is also lactation certified. And then let's see, I belong to a Facebook group that's also like all OTs in lactation. And most of the, like a lot of them are either private practice or like even in early intervention, you know, to be able to have that kind of little bit of a trick in your tool bag. I don't know that you would use it as much because most of our early on programs in West Michigan are unfortunately that interventionist model where they kind of are covering all of development and you can only spread so thin before it's just not something you're going to feel comfortable and confident in helping families on a regular basis. So, but yeah, other than that, I think you can work in just about any setting.
How do you think, especially in like the COVID climate, how do you think that infant feeding would fit into telehealth? Do you think that those that could work, or do you foresee that it would change it?
I know there are people that are doing it. I am not one of them, and I am old enough that I just don't know that I could wrap my head around being like, okay, could you take the camera and like, move it over here so that I can see this angle and like what's going on, and okay, I need it silent so that I can kind of hear what the baby's doing. It would be really challenging, but certainly I think there are pieces, and that you know, that mom that is desperate and has nowhere else to turn. There's no, like I said, there's no support groups going on right now in person. And so they are trying to do their best by like virtual visits and stuff like that. But in my mind, it's just not the same. And I think moms that I've worked with through COVID, they don't think it's the same either. They're like ecstatic that I'm able to be right there in the home with them and to be able to help them rather than, trying to like finagle the app, and if they get closed out of the app and the technical, like all of that kind of stuff while they're already stressed out with a baby that's screaming and hungry. And so it probably comes with its own challenge, different set of challenges, but possible for sure.
Is how do you and your employer, so Spectrum,
Mm-hmm.
market or advocate for this specialty area in OT?
Yep. So I got really lucky in that we have a foundation representative, or Spectrum Health Foundation representative that works in our office building. And she basically put together the proposal when I said I was interested in doing this and got my entire certification paid for. Oh. So that was one bonus. So from that standpoint, obviously, since they paid for it, they're a little bit more apt to support the program. and we give kind of annual updates to the foundation members of like what kinds of success stories we've seen, how it's going, and that kind of thing. And I would say that like it is fairly well supported. It's from my uplines for sure, that they know that it's something that I do. They support me to be able to go outside of my like typical territories to help consult with my colleagues if they have a case and that I need to go and see, so that I can lay my eyes on and need to do more than just talk with that therapist and give some ideas that way. And they don't think twice about letting me do that. So I feel relatively supported in that regard. But like I said, it's also stemmed from they like
very encouraging.
So yeah.
You have any suggestions for program development in a practice setting that maybe this specialty area doesn't exist in yet? Or do you feel that it's the emerging area has been addressed well in the settings that are possible?
I think one of the other really cool potential settings that you could get into would be into a pediatrician's office. And like, cause I know other lactation counselors that they do, that is like their job. They work in the pediatrician's office, and whenever a mom comes in with their baby for their well child visit or whatever it may be, they have that person right there to be able to like consult with them and talk with them. And that would be and I think you could easily market yourself that you could identify other issues or concerns that, a typical lactation counselor might not pick up on, particularly if you have some background in infant feeding and special needs feeding and stuff like that, that I think you really could market yourself at that point to be able to do some of that. Certainly getting in with those pediatricians, another spot where I know another therapist works really hard to market herself is in pediatric dentistry, because they're the ones that are doing the tongue clippings, the releases and stuff like that. And so she works closely with like a couple of dentists that will refer directly to her for private practice. And so I do think it's possible. I think, as you gain experience in different areas, you kind of take some of those pieces and who you've networked with, and you kind of mold and shape yourself. I've been the person that has kind of felt like I've slowly funneled down to my specialty, and it wasn't necessarily something right out of the gate out of school that I was like, I want to be an infant feeding therapist. I was much more like the open book of, I have a really big debt and I just need a job and I'll figure that part out later.
Mm-hmm.
And so I kind of, not that I totally went with the flow, but there were things that happened that kind of molded and shaped things for me, along with my own, like, I love this and I really want to go for this. And now I'm going to like build my repertoire of continuing ed in this area, and kind of now I'm in this area and this is where I see that gap and what we need to work on.
Now that you say, it seems so obvious that an OT should be like in a pediatrician's office.
Right?
Like, why aren't we there? We're everywhere, so why aren't we there?
And especially because you mentioned pediatricians as a main source of referrals. So to just have that immediately there and accessible would be great. So
absolutely, or that kind of thing. And I'm finally to a point where I literally probably would potentially take on kind of my own private practice in lactation or infant feeding if things were to like go awry. But I also personally very much appreciate having the larger system to be a part of from a stability standpoint. I like would really have a lot of anxiety about like much more anxiety about my caseload if it was like directly affecting my bank account, like those kinds of things. So that's why I personally have not like taken the leap into private practice, but there are definite opportunities. It's just a matter of whether you're billing under OT or billing under the IBCLC, like the lactation codes. Right. I generally bill under OT codes and charge OT, but there are therapists that charge under the lactation codes as well. So I even had a couple of cases where I had one case where mom had an upper extremity amputation and was wanting to breastfeed. And we were like, okay, so what do we bill that under mom? Do we bill that under baby? Like who's going to be the like patient according to the insurance company? Okay.
Well, speaking of billing and codes and insurance,
you
just helped us segue perfectly into our last question.
Bane of my existence.
We've heard about that too, and I'm not looking forward to that part. Is there any crossover between OT and other disciplines that you have to be particularly mindful or cautious of when you're treating and documenting and dealing with those third-party entities?
Yes and no. Obviously, from a lactation perspective, I don't worry about it as much, because if they were to see a lactation counselor and have that billed directly through them, I'm billing through OT, so they can have both. If I was billing under lactation codes, I'm sure that would be a different story. And then the one that I do have to be mindful of, obviously, would be speech, because if speech is seeing the baby for something, I have to make sure that we're not both seeing them for feeding, because that would definitely be a duplication. So, because in Spectrum, we don't separate out who is seeing, strictly the sensory feeders or the ones with swallowing dysfunction and dysphagia, because they all have overlap in that area. So I think they've tried to do that in the past, terribly unsuccessfully. And so really it's a matter of whose caseload and what insurance will cover which discipline, and that's who it's going to go to as referrals come in, rather than trying to be like, well, what are the specific needs? Because then that person evals and is like, this isn't my area, you take it. It doesn't work that way. And that's the other reason I'm thankful for a larger system, is we have a whole department that takes care of that and will come back to me if there's any issues. So I just do my job and do what I love to do and do my best to document, it the best I can. But if there's any issues or specific concerns, there's a whole nother department kind of double checking behind me and taking care of that billing aspect, and more responsible for that billing stuff than me. But they will sometimes come back and ask for clarification or what to do with a case if need be.
Well, Christy, those are all the questions we have for you. Was there anything that we didn't ask that you wanted to touch on?
I don't think so. But other than that, I do love what I do. I love that I get to work with infants. I get to work with the mother baby unit and success, and working towards feeding success. Like, the cliche advertisements where there's a mom feeding a baby with a bottle, and with one feeding by breast and one feeding by tube and everything like that, and kind of fed is best, is so true. Like, it's so absolutely true that I love that I can address all of it, that I can feel comfortable trying to work towards whatever is going to be best for that baby, and hopefully best for that mom too. And if breastfeeding is where we can go with that, fantastic. But also helping those other moms that might not be able to breastfeed to understand that really, truly, fed is best. And no matter what that looks like or what that means, that very reason. And I would wholeheartedly encourage whoever's interested in that to realize that any of your mental health placements or things like that, I will never forget. I ended up with one of my level 2 placements. It was supposed to be in pediatrics and it fell through, and I ended up at Forest View Psychiatric Hospital. And I literally was in Cynthia Grebzinski's office crying because that was not what I wanted. I did not want that placement whatsoever. And in hindsight, it is 110% the placement I needed, because yes, there's a lot of things that we do therapeutically, but our therapeutic use of self, particularly in pediatrics and infant feeding, 100% is steeped in that therapeutic use of self and that mental health piece. 100%. I would never trade my level 2s ever again. And so if it's comforting to either of you, neither of my level 2 clinical fieldworks were in pediatrics. And yet I'm here where I am today. So it is totally possible, and they know what you need, and just trust them, and it 100%. I ended up where I should be today. I love what I do. And like I said, that placement, I cried. I did not want to go there. By the end of it, I would have taken a job if they offered it to me.
So thank you so much for your time and for your enthusiasm for OT and your specialty area. It was really great chatting with you, and we really appreciate it.
Well, thank you so much for your time. We really appreciate it.
Awesome. Thanks, guys.